Welcome to Robert Wood Johnson University Hospital, Somerset's Health Talk. I'm Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group's Warren Internal Medicine. If you're like many Americans, you're not getting as much sleep as you need. Whether it's binge watching, caring for a newborn, or a sleep disorder that's keeping you up at night, not getting enough sleep can affect your overall health. On today's show, we will talk more about the importance of sleep and tips for getting a good night rest with our special guests, Dr. Matthew Scharf, Medical Director of Robert Wood Johnson University Hospital, Somerset's Comprehensive Sleep Center, Karen DeRusso, the manager of the Sleep Center, and Samer Gerges, Chief Technologist at the Sleep Center. Welcome to our show. Thank you all for coming here. First, so that the audience knows who you are, let's start with a little background information. We'll first start off with Dr. Scharf. Tell us a little bit about yourself, your background.
I am a neurologist and a sleep specialist. I did my training at the University of Pennsylvania, and I've been on the faculty here now for about three years. My research interest and most of my work really focuses around sleep disorders and its effect on health and other diseases. And then I also do practice some general neurology as well.
Thank you. Samer?
Yeah, I am a registered sleep technologist. I've been in the sleep field for more than 10 years. I'm also certified in clinical sleep health, and I'm a clinical sleep educator also.
Thank you.
And I'm the chief technologist in the house.
Thank you. And Karen?
So I've been in sleep for about 35 years. I'm a registered sleep technologist. I have a bachelor's in science from Rutgers, and currently the manager of the 8-bed lab at Robert Wood. I've been with Robert Wood for all of my sleep career.
So let's start off with sleep. Something that most of us don't talk about. You know, primary care doctors don't talk about it, specialists don't talk about it, but it's so important to our lives. Tell us a little bit about sleep, why it's so important to us, how much sleep people really should be getting.
Yeah. So I think that with time we've learned a lot more about sleep and the fundamental role in general health. We know that sleep and sleep deprivation can have profound effects on health in terms of health of your heart, health of your brain, health of your other organs, and also, as we obviously know, just how well you feel, how well you perform, how well you are able to perform and do things in your life that you want to do. There's no exact number for how much sleep a person really needs, and it does vary with age. Small children need a lot. Little kids may need 10 to 12 hours of sleep. And a young adult, probably something in the range of 8 to 9 hours. And an older adult, probably closer to 7 to 8. But it does vary a lot within an individual. So those are just some sort of general numbers.
And we know that sleep affects our overall health. In fact, Charles Dickens wrote a whole novel, Pickwickian Papers, all about sleep apnea. Yeah. So tell us, how does sleep actually affect our overall health?
So sleep can affect it, I think, in a number of different ways. So sleep is something that we're still learning a lot about. Sleep is something that we've recognized the importance of it for many things, but the mechanism and how it does it is still not completely clear. And in fact, in the sleep field, we're still debating what really the overall function of sleep is. But we think that one idea is that, when you're awake during the day, you're involved in a lot of different kinds of activities. Your brain has to process things, always has to be active, has to do things, and those have costs, just like doing things in life have costs. They have costs for the amount of energy used, they have costs for how your cells go and produce proteins and function normally. And during sleep, we think one of the functions of sleep is to replenish a lot of those energy stores in the brain that have been depleted during wakefulness, and as a rejuvenating process. And we know that when people don't get enough sleep, we know that a lot of those processes are negatively affected.
And we know that, for instance, someone who has hypertension, if they're not getting a good night's sleep, that'll affect their blood pressure control. Heart disease, the same thing.
Yeah.
If they're not getting good sleep, that will definitely increase their risk of developing atherosclerotic heart disease.
Yeah.
So tell me, what are the most common sleep disorders that are out there?
So I think that there's a few that are very common that we see in our population. Probably number one on the list is obstructive sleep apnea. Obstructive sleep apnea is a disease that's caused by collapse of the upper airway during sleep. In fact, I usually, in my office, I tell my patients, I say, imagine your breathing tube is a hollow tube. And when you go to sleep at night, it collapses. Open, close, open, close, open, close. And when that happens, oxygen levels can decrease, and it can cause people to wake up during the night and have an unrefreshing sleep. So people with obstructive sleep apnea may present with a lot of sleepiness. They may present with very poor quality sleep, and then other associated symptoms that we don't necessarily even think of as being necessarily related to obstructive sleep apnea, like having to urinate frequently during the night, which is extremely common, heartburn that's worse really later in the night. And these are some very common things that we see. So I think that, and one of the major risk factors for obstructive sleep apnea is unfortunately obesity. And as we all know, we have an obesity epidemic in the United States and worldwide, and that has increased the prevalence of obstructive sleep apnea by a lot. And so that is probably the most common sleep disorder that we see. And sadly enough, it's actually still being, it's still undiagnosed in many, many, many patients. And for some patients, it's really, unfortunately, a catastrophe that really brings them either a health catastrophe or a car accident or something like that, that brings them to care.
And that brings us to the fact that with obstructive sleep apnea, it's the diagnosis of it.
Yeah.
It's the fact that you have to actually think about it at the time that you're seeing a patient.
Yeah.
And unfortunately, many of the primary care doctors out there are not thinking about that at that time.
Yeah.
But if you have someone who is somewhat overweight, it's something that should always be in the differential diagnosis.
Yeah, absolutely. And in fact, it's a really good question because that's something in the sleep field we have been talking about to a lot of primary care doctors because, that's the primary care doctors are the gatekeepers, for the healthcare system for most of our patients. And I think that's really extremely important. As we know, primary care doctors I don't have to tell you, are busy people, and unfortunately getting less and less time to deal with more and more problems and more complex patients. So there are a number of screening questionnaires that people can do. Doctors can do them in their office, and patients can even do them online to get a sense of if they're high risk or low risk for sleep apnea. And one that I would recommend is what's called the Berlin questionnaire. You can actually just Google it. Doctors can do it in their office, patients can do it at home, and they ask some very simple question about the patient and their age, their gender, their weight, their height, and then a few questions about sleepiness and snoring and breathing pauses during the night. And that the patients will go and enter the information, and that will give them either a score of high risk or low risk. And the patients on these questionnaires that are deemed to be low risk really are low risk, and the ones that are high risk are the ones that really should then go on for further screening. And I think that one of the things that has happened more over time, just because primary care doctors are so busy, is that once they identify these patients, sometimes primary care doctors will go ahead and order the sleep studies, but nowadays, for various reasons, that's become more difficult. We just now, sort of the standard has become more and more that they just get referred to see a clinical sleep specialist to manage it. But I think that's a great question, and I think that primary care doctors can do that screening test. You can give a questionnaire to a patient to fill out, or patients can even do it at home, and you get a little printout. They could bring it to the doctor's office, and those people should definitely be referred for a study.
And it's even the sleep partner.
That's actually a really good point because a lot of times those are the people, that's one of the most common causes for a consult, which is, why are you here? Well, my wife told me to come, And that's really, and the sleep apnea can affect not just the sleep and the health of the patient, but also of the spouse. And in fact, that's pretty common for us to see where spouses are in separate rooms simply because the spouse needs to get some sleep and they can't with listening to the loud snoring and the breathing problems that the patient has.
And that brings us to the sleep lab itself. Okay, so as a primary care physician, I've gotten a positive, I think that the person has it. So I'm sending them over to Robert Wood Johnson University Hospital, Somerset's comprehensive sleep lab. What happens when I send the referral to them?
So we go through a process of registration, checking their insurance. We have to see if they need an authorization. We keep in contact with the patient to let them know. It's sometimes a long process because of insurance. And once we get all the information we need, the benefits and the authorization, we'll call the patient and we will schedule them for either an overnight study or a home sleep study, depending on what the doctor has ordered or depending on what insurance has decided they can have. So they may have been ordered an attended overnight study, but insurance says no, they can only have a home sleep study.
And prior to them coming, do they get a consult with Dr. Scharf or one of his physicians?
If the referring physician would like a consult, then we do that first. Sometimes the referring physician wants the study to be done and then the patient follow up with the sleep specialist. But there are some referring physicians that do treat the sleep patients themselves.
Okay, they come to the sleep. We've gotten the acceptance from the insurance company. They're coming to the sleep lab. What should they expect when they come? First, how should they dress? What should they bring with them? Should they bring their teddy bear that they sleep with at night?
Absolutely. So if they're coming for an overnight study, they will come dressed normally. They should eat before they come. They can bring a favorite pillow if they want. We have a full room. It resembles a hotel room. So we have all the bedding. We have a private bathroom and TV and temperature control. But absolutely, we encourage people to bring with them anything that might help them sleep. And besides the children bringing teddy bears, there are some adults who do bring their favorite stuffed animal. So they're greeted at the door by their technologist. We're all registered technologists there. They're brought to their room. They can then get changed into their pajamas, fill out some paperwork, and then their tech comes back in to do the hookup. So the hookup, it consists of about 26 sensors. And during the process, the tech will explain what patient can expect, and they will talk about their sleep, or if they have any questions, the tech will answer questions during this hookup process. There are electrodes put on the head, the eyes, the chin. We're looking at brain waves, eye movement, muscle tone. Those are the 3 parameters we use to determine sleep stage. And there will be elastic bands around the chest and the abdomen. Those are looking at respiratory effort. There'll be a cannula looking at airflow, an oxygen sensor, a snore sensor. And those are the parameters that we use to look for sleep apnea. There will also be electrodes on the legs to look for leg movements and EKG electrodes. And it sounds like a lot, it is a lot, but people do acclimate to all the sensors and they do sleep. And they can watch TV or read until they're ready to go to sleep, and then we start the study.
And how long does the study last?
The study will last probably 6 to 7 hours. They usually start around 10 p.m. and we end around 6 a.m.
Like usually the lights out for the adult, we put the lights out around 10:30 to 11, and we wake the adults around 5:30. And for the beads, we wake them up at 6 sharp in the morning, and it's depend what time they go to sleep. It's depend on the baby, like if they go up early, so we accommodate this. So they go up around like maybe 7 till 10, and we wake them up at 6 o'clock. But we still accommodate, like if some patient, he said like he wakes up at 10 o'clock, we usually receive this from the family or from Dr. Scharf. He said, this patient, he has a specific time to wake up. So we accommodate other technician. He comes in the morning and he take over, and the night takes leave, and we wake up the patient at 10 o'clock if it's needed.
Well, yeah, we're a 24-hour lab, so frequently Dr. Scharf will give us a prescription very specific that the patient's going to start the study at 2 a.m. because they sleep until the afternoon. So we do that. We have the night tech start, and then the morning tech takes over and continues the study.
So we do them for shift workers, someone who has one of those late night graveyard shift ones.
Yes.
Yeah, because for a lot of patients, they complain. It's a big worry for patients that, if a patient they're used to working the late shift and they go to bed at 3 a.m. and they sleep till noon, and we bring them into the lab and we tell them we're going to get them up at 6 a.m., they're worried they're not going to sleep that much. So the lab is great on terms of accommodating those people. And I do give them all kinds of weird schedules, very early, Sam's laughing, or late. And then we do sometimes these nap studies, and we have all of these detailed. And one of the advantages, like Karen said, of being a 24-hour operation is we can accommodate those things to really try to best accommodate patients and their natural sleep rhythm.
Okay, so we do a sleep study. We get all of that information, and it comes back to either the physician or the consult with Dr. Scharf, and it comes back that there's a suggestion of a chronic obstructive sleep apnea. And so now the consideration is CPAP. So, Samer, you want to tell us a little bit about what CPAP is and how it works?
So CPAP stands on it's continuous positive airway pressure. It's like the pressure of the air act like splint. Like we connect the patient with mask. There is different kind of masks. There is a nasal mask that covers the nose only. There is a full face mask that covers the nose and mouth together. There is a nasal pillow, which is only pillows goes in all the three masks, they do the same like each other, but it's related to the patient. Some patients, they are open their mouth during the night, so those kind of patients, they need the full face mask. Some patients, they only use their nose, so those patients, they use a nasal or nasal pillow. So we connect the mask to the hose, and the hose connected to the device, the CPAP device, and then we turn the device. The device, it is like graded with the pressure, between pressure 4 till pressure 30. Like the pressure, it's like the dose for the medication. Some severe patients, they needed high dose, and some mild patients, they needed low. So we start with the lowest pressure, which is 4, and the technologist is watching the patient during the night. If the patient continues having event, like he still have obstructive sleep apnea and his oxygen goes down, so we have a protocol, so the technologist follows the protocol. He increases the pressure, so the patient feel more air during the night. And as the night goes on, whenever the technologist watches, there is an event, there is a micro arousal, there is a desaturation, so they pop the pressure up. Till he sees that the patient is relaxedly sleeping and there is no event, his oxygen is normal and he's in REM. So in this case, it will be the final pressure. And it's end up it's up to the doctor. He decide which pressure is good for the patient because he reviews the whole study and he will see which is the best part that the patient was sleeping, like he was in REM, rapid eye movement, or dreaming in his back. So this is the supine REM, so this is the best pressure. So he decide which will be for the patient to use.
So you get back all of that information, and what do you do with that information?
So I always have a conversation with the patient in terms of CPAP and then other treatment modalities, because it really depends on the patient. And for some patients, CPAP is a great choice, and some people really thrive with CPAP. And for other people, there are alternative treatments. So Sam described CPAP very, very well. One of the advantages of the modern day CPAP machines, by the way, is that we have automatically adjusting machines. So for people that need higher pressures that can't quite tolerate them, the machines automatically adjust. There's a built-in humidifier, so it makes it very comfortable for patients, particularly in the wintertime where you have this cold, dry air. It makes it very comfortable. But I have a conversation with the patients about CPAP, and for some people, alternative treatments, like, for example, the mandibular advancement device, which helps pull the jaw forward. For some people, sleep apnea is really just on the back, like Sam was saying here before, and there are positional devices to keep people off their back. And then there's a hypoglossal nerve stimulator, the Inspire device, which is out there. People have often heard about commercials on TV or on the radio for it. So I always discuss with the patients all the different options, and then we go and then formulate a plan for moving forward.
And if we think that it's going to be a CPAP mask, what do we do? How do we send the patient home?
So it depends. So if they've had an in-laboratory study, that is ideal, because what happens is they've fit the patient for a mask, and Sam has outlined some of the concerns that we have, what kind of mask. And in our reports from that, we write what kind of mask. And very often the patients will try several kinds of masks during the night, and we'll find one that works for them. And if that's the case, we can then go ahead and order that mask. if we don't have a titration study, which has become more and more common with insurance requirements and so forth, we will give them an order for a CPAP, and then when the company comes to set them up, they will show them some different options over which mask to use. If I had my preference, I would set up patients with at least 2 or 3 different masks, but as you can tell, I don't work for the insurance company, so unfortunately that doesn't usually happen. But it's very important to know that with patients, when they have a mask, if they like it, great, and if they don't, the manufacturers have a deal where they can swap it out for free within 30 days.
So it's important that the patient knows that if they're going home with the mask, that comfort's very important.
Yes, absolutely.
And that the fact is, if it doesn't feel right, they really should contact the manufacturer or whoever the supplier is and have a new one brought to the house and do another trial on it.
And in fact, I tell my patients all the time, I say, look, try working with the company, and then unfortunately, because of the insurance requirements and all these things that we have to go through, it's getting harder to do it. But in an established sleep program like ours, we have many ways to address these problems. So if I tell patients, if you try your CPAP and you have some problem with it, don't just put it on the shelf and never show up again. Even if you can't, I want you to come back. I want you to call me. I want you to come back to my office. I want you to tell me what's going on. And very often the problems that people have initially in CPAP are addressable. And we think that's really, really important because actually probably the biggest predictor of long-term CPAP use is early CPAP use. And that includes within the first week. So we really feel very strongly about doing everything we can to really try to maximize it and make it comfortable and optimal for the patient early on in order to ensure that long-term success.
Which is, again, very important for them to use it.
Yeah.
We may be able to diagnose and treat it, but unless we're going to use the mask, it basically is another, it's something else that they keep in their house and don't use.
Yeah.
And proper mask fit is crucial to the use of the CPAP, to the compliance.
And proper taking care of it. And once a year at least coming back to the comprehensive sleep center and just recheck that everything is working correctly and that this is the same numbers that they should be, because maybe the person did lose a lot of weight during that year.
Yeah.
Right. And
Like if the patient doesn't like the mask, he need to call the physician. He can come for mask fitting. For the mask fitting, we show the patient different kind of mask. We refit him with the mask. So it's not too late. If you don't like the mask that you went home with, you can change it.
Yeah. And at the sleep center, I actually tell patients, we have a room that's filled with masks, and it's just mask after mask after mask. And on the market now, there's probably over 100 kinds of masks, and everybody's face is different. Everybody's preferences are different. And I tell my patients all the time, I can't look at you and say you're a X kind of mask. And people just have to try that. So there's a little bit of fitting, which is very important. And then also, when you fit a patient when they're sitting here in a chair, that's one thing. And when they go to sleep at night at their home, that may be different. So I think that's really a critically important thing. And one point that I want to just re-emphasize is if the first one doesn't hit it, that's okay. I had one patient who the first 8 masks were no good. And when he got his 9th mask, that was perfect. So that's an unusual story, but 2 or 3 is pretty typical.
From now on, we'll start with the 9th mask.
Okay.
And while we're doing all of this with the sleep study, it's not only the diagnosis of the chronic obstructive apnea, but maybe you're going to also find restless leg syndrome, which is another thought, another thing that people come to the office asking, do I have it?
Yeah, it's a really, really important complaint for people. And studies have shown that actually really depends on the population, but anywhere between 5 and 15% of the population has restless leg syndrome. And for restless leg syndrome, it's really a terrible thing for a lot of people that really suffer from it because they get this unbelievable urge to move their legs, and it tends to occur at night when they're trying to go to sleep. So they're trying to go to sleep, but they feel like they have to move them, shake them, get up, and walk around. And the thing about restless leg syndrome is that it's really pretty bothersome for a lot of people, and it's really readily treatable. We have non-pharmacologic treatments and then pharmacologic treatments. So the non-pharmacologic treatments that we would have would be things like massage, heat therapy, there's different kinds of devices for that. And then the pharmacologic ones, we prescribe these in the office. And for most people with a little bit of either non-pharmacologic or pharmacologic therapy, it's addressable. They feel much better. They're very grateful, and they do a lot better. In fact, just an anecdote, I had one patient who was really miserable, and I treated him, and one of my trainees saw him and said, "This guy is so grateful," and I walked into the room and he gave me a bear hug, and a lot of patients are really, really grateful, and treatments are available. So that's a really important question that people should ask and bring up. And just as an aside, a lot of people have a lot of difficulty describing the sensation. And they're reluctant to tell their doctor about it because they think the doctor's maybe going to think they're crazy or something like that, because it's hard to describe for a lot of people. But I encourage people to bring it up, because if it's really bothersome, then that's something we really want to address.
And the fact that since they do have it, that's going to interfere with their sleep and again affect how they, if they sleep through the whole night, if they have to get up multiple times to go to the bathroom, if they have to do massaging of their legs at night to help get through it. And if we're going to not get a good restful night of sleep, that will affect their overall health.
Yeah, absolutely.
Yeah.
And we diagnose it during the sleep apnea. Like during the sleep study, during the night, we have electrodes connected to the legs, so we can diagnose if the patient he have.
Well,
So
that's why
during
it's
the
so
sleep
important for
study,
you
the
to
end
put
levels
on all of those probes, even though it looks a little interesting having 26 probes on you as you're trying to sleep. You're getting to the root of the problem.
Exactly.
Yeah, what Sam is describing what are called periodic limb movements, which can occur with or without restless leg syndrome, but they're extraordinarily common. And for some people, they disturb sleep. Sometimes spouses get kicked in the middle of the night, so another hard thing for spouses sometimes. And these are treatable problems.
Which is so important why Robert Wood Johnson University Hospital Somerset comprehensive sleep center is so important, because it's not only you're diagnosing the little things, you're diagnosing the overall components of the sleep, hopefully to improve the sleep, improve the person's overall health. And what it sounds like is if we can possibly get the insurance company to accept in the comprehensive sleep center study, it sounds like it's a better study than if we have to do it at home.
Yeah, I mean, so it's a good point, because we should talk a little about the home sleep testing.
We actually can't, because we're actually out of time.
Oh, okay then. All right then.
We'll do that next time.
Next
though.
time, okay.
But it was more important that the people learn how important it is if they're going to have sleep apnea, sleep insomnia, narcolepsy, to be referred to Robert Wood Johnson University Hospital, Somerset's comprehensive sleep center, and go through the whole process. This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember, the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. Download the RWJBarnabas Health Connect app to schedule doctor appointments online and manage your health records right from your phone or tablet. For more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you all for being here, and thank you for everything that you do for Robert Wood Johnson Barnabas Health.
Thanks for having us.